kind of how I got to where I got to, and also talk a little bit about what it's like for a day-to-day life of a nurse practitioner. So as the title of my presentation, when I was thinking about this, I talked a little bit about, where I started, which was in the emergency medical services. I always say that I grew up in the back of an ambulance, and it was always a lot of fun. I started joining the emergency medical services when I was 16 years old, to now where I'm a critical care nurse practitioner. I'm also one of the advanced clinical provider supervisors. So similar to, I believe you guys spoke with Arthur Schulfer, who's one of the PAs. We both hold similar titles as advanced clinical providers, supervisors, overseeing some of the programs at Lenox Hill. So to talk a little bit about kind of how did I get here? Like I said, at the age of 16, I was in high school where I was offered to be in a program known as Certified First Responder. And Certified First Responders are kind of the entry level in the emergency medical services. There's a lot of, different occupations such as fire departments, police officers who are certified first responders, which you're trained in things like first aid, how to think about response in an emergency type of setting, and those type of things. And at 16, I became a certified first responder, and it was something that was really intriguing to me. The idea of being able to help people during an emergency situation was really kind of cool. And I think at 16, it was super cool to be able to say, hey, I know how to take someone's blood pressure, or hey, I know how to deliver a baby, or things like that. And then over the years, I rose in the ranks in the emergency medical services. I had the opportunity to become a EMT out of high school. So at 18, I was being trained. Back then, I had a high school teacher named Victor Minlin, who was a New York City EMT for a very long time, and was showing us all different kind of cool things, from everything from oxygen therapy to, like I said, delivery of children, to managing mass casualty incidents and things like that. And if you kind of look at this panel over here, you'll see there's different levels in the emergency medical services. There's something called an EMT basic, and then even back in the day, and this is something to think about, to talk a little bit about my age, back in the day there was a certification called EMTD, which stood for defibrillation, meaning that you knew how to use an automated external defibrillator, which is really the standard of care now. For anybody who kind of goes into medicine, you should be able to know how to use an AED, and you also should be able to utilize an AED as a bystander, learning those different types of things. Then I became a critical care technician, where I learned how to be an advanced life support provider. And so with advanced life support, and it's kind of like a stage-wise process, right? So you kind of learn about different aspects of care, from basic life support, then adding things like being able to start an IV, being able to intubate a patient, put a breathing tube down to help them breathe or ventilate them, adding on other things like delivery of medication, so being able to treat things like anaphylaxis, being able to treat shock, etc. And that was a lot of fun for me. In the emergency medical services, one of the really great things about it is there was so much camaraderie. You're working on the streets with fire department, with the police officers, with all of these different interdisciplinary team members. And, you got to have a lot of fun with it. When there was downtime, you got to see New York City in a completely different light. And then when, you had to act, it was all about the adrenaline. And that's kind of something that made me always fall in love with the emergency medical services. I really like to think quickly on my feet. I like to think about, and think about what different things I need to do to kind of treat patients right away, etc. And so I joined going to college. Like I said, I started off at the age of 18. during high school, I kind of thought a lot about what are the different pathways that I wanted to go into. I had one of the nice things about my high school is we had the opportunity to kind of do internships. And during internships, I, worked at NYU in their dental library. I also shadowed a lot of oral maxillofacial surgeons. I also worked in, the hospital and kind of had a lot of different experiences. And so when I went to college, though, it was completely different. I actually started off college as a computer science major. And I think that that was a time, again, nowadays, especially now with everything being virtual, and, computers are like the big thing. Back then, I had graduated high school in 2000, and that was like a time where like computers were becoming very popular, and I was learning how to like code my own web pages and everything like that. And so I was like, what a great career. I would love to go into becoming a software engineer or learn more about computer science. During that time, I sat through my first computer science course, and all of the Boolean algebra of zeros and ones just was not for me. But one thing that I did kind of find was that I knew that I wanted to utilize my EMT skills. And so I utilized my EMT skills by finding a local ambulance company. And so here you can see photos of the local ambulance company that I was involved in. And I fell in love there. I fell in love with emergency medical services there. You can see it was such a big family. There was a lot of friends. We would train every single day. And we trained for a lot of different scenarios, everything from, a building collapse to your standard overdose that you might see on a college campus, et cetera. And we responded to a lot of different emergencies, not only just on campus, but also in the towns around us. And that's where I kind of learned a lot about what it meant to be part of a family. And I also learned a lot about what it meant to be a leader. So during that time, I was one of the field training officers where I would train a lot of new EMTs and kind of get them to learn the ropes, and then also train on becoming a critical care technician and advanced life support. So I was one of the Suffolk County field training officers for team members who wanted to become, advanced life support providers. So that would be training them on how to put in IVs, what medications to deliver, intubation, all of these advanced different types of procedures. During that time, I also held the role in multiple different types of things. So just like multiple organizations or governments, you have your different branches. There was an executive branch and an operations branch. And I spent time over the years on both branches. I was president and treasurer at one time. I was also one of the first assistant chief of operations, where I had overseen the advanced life support program there. I also oversaw the training of our team members, from whether we used to call them probies or probationary members, who are brand new team members who are trying, wanting to move up the ranks into emergency medical services and kind of learn the field, and then also the advanced life support providers from, the paramedics and the critical care technicians. And it was during this time where I really kind of found that this was my niche. I was doing it every single day. And I would work very long hours because I was passionate about it. It was fun for me. It wasn't a job. And I think that that was one of the things that, I learned over time, is to learn that find the things that you're passionate about, because those are the things that are going to make you really happy. And that's where I ended up working in an emergency department. So I started off my career as a critical care technician or clinical assistant at Stony Brook University Medical Center, which was a level 1 trauma center. I worked in the emergency department. Some of the things that I did on a day-to-day as a clinical assistant was that I would help to stock the rooms. I would help involved in patient care. So we would draw blood, do EKGs. But one of the places that really that I found that I really enjoyed was shock trauma. This is a picture of shock trauma. Shock trauma is, and every single hospital has a place like this. It is the resuscitation room of the hospital. And in shock trauma, it was about a 7, sometimes we can flex to like 12 bay trauma bay where the sickest of the sick patients would come in. It could be a trauma such as a rollover crash. It could be someone in cardiac arrest. It could be someone who just had a gunshot wound. And I worked in shock trauma. And what I loved about working in shock trauma was that I learned a lot. And I give credit to, Stony Brook's emergency department for teaching me so much about medicine and about caring for critically ill patients. And I learned it by doing. Now, mind you, at this point in my career, I was an advanced life support provider. I had some basic information. And when I think about it, and I think about like when I was reflecting on putting this together, I think about what it was like back then to what my knowledge base is now. And back then, I had really a lot of like technical skills, right? Like I learned how to put an IV in. I learned that, hey, if this happens, I'm going to give this drug, etc. If someone goes into ventricular fibrillation arrest, I know that I have to defibrillate them, and I would go ahead and give them the amiodarone, etc. There's one thing that's really funny in emergency medical services when they talk about advanced life support. Back in the day, it was like their sugar's low, you give them the blue box. Why? Because the blue box was dextrose. If someone overdosed on something, you can give them the orange box. That's Narcan, right? Naloxone. If somebody goes into cardiac arrest and you're doing CPR, you give them the brown box, which is high epinephrine, 1 to 10,000. And so it was very like structural, algorithmic, things like that. If someone stopped breathing, I would go ahead and intubate them, put a breathing tube down. But one of the things about working in the environment like the shock trauma bay was that I got to work with a really great interdisciplinary team of, nurses, doctors, PAs, all these people who taught me just by doing. They role modeled. And so I worked in the trauma bay and I kind of got to see a lot of really cool things. I knew every single tray there was in there, from a chest tube tray to a thoracotomy tray. We saw a lot of ventriculostomies. It's interesting you talk about this on brain turns, which, is like a EVD is like Dr. Langer's every single day. But, one of the things that we saw a lot in the ED there, we did see a lot of head trauma. And so, or patients with like aneurysms and things like that. So we were putting in ventriculostomies in there. And again, at that time, I was technically just like an aide, right? My title was a clinical assistant, but I learned so much from the nurses. I learned so much from the doctors. They really took me under their wing. And when I think about this, it got to a point where I gained the trust, and over the years I got to see all of the different things that happened. There's so many stories that could be told in this trauma bay, and whenever I look at this picture I get nostalgic thinking about all the lives that we've saved, all the lives that we've lost in that trauma bay. And it's really something that sticks out in my career. I learned how to participate in open thoracotomies, and I say before I even went to nursing school, I could probably tell you and be a first assist in an open thoracotomy because I got to see it so much. And that was one of the great things. And that's one of the great things about healthcare, is that you learn so much just by absorbing, by being there. And so I give you guys a lot of credit for being here this summer, in Brain Turns, because you're going to have one step ahead no matter what field of medicine or nursing that you're going to go into, or being a PA, because you're already absorbing so much, right? And you're already like, oh, that's cool. Now, do I think like you're going to go and perform the next brain surgery? Probably not. But will you know a little bit more and have, your feet wet? 100%. And so this is one of the trauma bays there. Like I said, it was shock trauma. That trauma bay is actually no longer there. Obviously, as buildings evolve and everything like that, there is a newer trauma bay. But, I look at this picture again and I think about how much of this has influenced my career. over the years. And so during that time, one of the things about working in that trauma bay was I got to work with some really, really cool, um, lack of a better term, badass nurses. And, you know, one of the things that I always looked up to the nurses were they were the ones who were doing everything. So, you know, this slide says, what do nurses do? And I will say, well, what don't nurses do? Or what are the things that nurses are not doing? They do a lot. And one of the things that we do a lot are we perform physical exams and health history to make critical decisions. And I think about all of the nurses that I worked with in that trauma bay. The nurses at Stony Brook, one of the things that were really, really great about them was that they took a lot of pride in what they did. And I go back and I think about nurses that I worked with, like Juan Cerna or Mikey Trauma, which is really funny because Mikey Trauma worked in the trauma bay. But they were these professionals who knew exactly what to do. They didn't need anyone else tell them how to do their job, and they took care of patients really well. And one of the great things about nursing is that you take care of the patient in a holistic way. So you not only are thinking about the medical aspect of it, so I can go ahead and tell a diabetic, or someone with hypertension who has high blood pressure, hey, you really need to decrease your salt intake, right? And maybe you should try to go ahead and eat these vegetables. That's what we do in medicine, right? Like, oh, you need to avoid this, etc. But as a nurse, one of the things that we are really great at is we look at the holistic view. We can go ahead and say, well, what is it like? I still remember one of the first times that I ever had to do teaching for a patient, and counsel them when they had high blood pressure. They had come in for a hypertensive emergency, and I had to counsel them. And she looked at me and she said, I have 5 kids, and you know, it's really hard for me to go ahead and go buy fresh vegetables when a can of vegetables in the United States is like 79 cents. You can get a can of spinach for 79 cents that's loaded with sodium versus going ahead and spending the $2 for fresh spinach, you know, where you're not going to put as much sodium in it. And so that's one of the great things about nursing is that we think about a lot of those different things in a holistic way. We provide health promotion, counseling, and education, administer medications and other personalized interventions. They coordinate care and they collaborate with a wide array of healthcare professionals. That's one of the things I loved about nursing was that at the end of the day, all the care that's being delivered, and you can say, you know, I'm a physician, I'm a nurse practitioner, I'm a PA, whatever you are, it's the nurses who are at the bedside. They're watching every single change. They're going ahead and helping and being a part of every single intervention that's happening. They're delivering the care that we're going ahead and writing orders for. And they work in a variety of different settings. So everything from emergency medicine, critical care, medical surgical, school nursing. There's all of the different things. You can work in leadership and nursing education. And I kind of went through a lot of these different pathways. And so, you know, when I look at this picture and I look at these pictures of all of the heroes, whenever we talk about, you know, COVID and we talk about the pandemic and we talk about the heroes, you have to give it up to the nurses. They were in the room. And I remember that because as much as I'm somebody who, as a nurse practitioner, I write orders, I do things, I go into my patients' rooms with the nurses, it was the nurses who are truly at the bedside, who are watching every single thing for that patient and really protecting our patients. And so that's one of the reasons why I fell in love with nursing. Because it allowed me to have that medical model, but also have the nursing model with it. So I went to nursing school, and it was because of really great influences that taught me, you know, what nursing was. Like I said, all of our nurses were board certified. They took a lot of pride in the work that they did. And I graduated from nursing school knowing that I wanted to do emergency medicine or critical care. And I got a lot of different job offers. You know, I think that that was something that you learn when you're in school, is you learn about how do you brand yourself, how do you make sure that people really, you know, are looking out for, you know, you. I always tell people that I orient or anything, hey, when you're here for orientation or you're shadowing or whatever it is, it's a job interview at the end of the day, right? I want to make sure that you are fit for the job just as much as you really want to enjoy being part of that job. So how did we get here? When I graduated from nursing school, I knew that I wanted to go into some type of emergency medicine or critical care, and I joined emergency department critical care fellowship at University of Rochester Medical Center, which is in upstate New York. And one of the things that I grew up, saying how much I loved being in the ambulance, but I also worked in a trauma bay. And so I found my heart in Strong Memorial Hospital in their trauma bay. And Strong Memorial Hospital is a tertiary care center. So in upstate New York, one of the things whenever people think New York, they think New York City. New York City is where I grew up. I grew up in Brooklyn, and it's a very dense area. And, but most of New York State is actually very rural and kind of separate from a lot of different things. And so Strong Memorial Medical Center is a level 1 trauma center. It's staffed by University of Rochester. It's also known as University of Rochester Medical Center. And that's where I learned a lot about taking care of critically ill patients as a nurse. It is a tertiary care center, meaning that everything gets flown into them. All of the critically ill patients in the surrounding areas get flown into them. So patients that needed like left ventricular assist devices, or maybe needed to see someone like a specialist like Dr. Langer or his team, those different types of things. And so I used to remember that as a brand new nurse, I was fascinated and really loved going up to the helipad. I loved working with different trauma patients. So we would get all types of trauma patients, from gunshot wounds to people who fell off, multiple feet from like a deer stand, like they would go out hunting and they fell off a deer stand, to people who were, driving at like 80 miles an hour, hitting, a deer or rollover. We saw a lot of Amish community members because they would have their accidents out in the Pennsylvania area, and they would get flown into us. And what I loved about working in that trauma bay was I loved going ahead and going to help offload trauma patients from the helipad. Why I loved it was because if you look at this picture over here on the left of a patient being offloaded, that is the calm before the storm. Because typically in the trauma bay, you'd have like 20 to 30 people waiting on that one patient. And we'd be doing all these different interventions, from putting in a chest tube to intubating them to, having all these different services come and see you. And one of the nice things about working in there was that I was able to go upstairs and really kind of take a breath of fresh air, be able to see everything, see the entire city of Rochester. It was super hot because you had to wear lead and wear a trauma gown on top of everything. But that was the great thing. And so working in the trauma bay, I made some really great friends. On the right, you can see a picture of Joe Gervasi, who is one of the other trauma nurses that I worked with. And then as well as Regina, who is one of our techs. And I always used to love saying how important it was to find the team that you really wanted to work with. Joe is the sweetest person who always made sure that every single patient's family member, every single patient was treated like his own family member. And Regina, again, was one of those techs who I empathized with because I was in her position, and that's kind of how I learned about life and about how to care for critically ill patients. And that's what it is all about. At the end of the day, you guys are all here to learn about different medical professions, and it's about the team. Nobody can do it alone at the end of the day. And that was one of the great things that I learned there. And then I got older, and I worked there for about 6 or 7 years. I worked as a critical care trauma resuscitation nurse. That was my title. About 80 to 90% of my shifts were working in the trauma bay. The other 20% was working as a charge nurse or a triage nurse in this level 1 trauma center. We saw hundreds and thousands of visits every year. So it was a very busy place, and I learned so much about pathology. But I decided that, at one point that mom and dad were getting older and I needed to come home and help take care of mom and dad. And that's how I landed at Lenox Hill Hospital. And it was really interesting because at that time I had, a few years of trauma experience under my belt. I had a lot of, critical care experience. I was very well known for being a pretty decent emergency department nurse. And if anybody knows about emergency medicine, it's one of the harder fields to be in. Why? Because you know a lot about a lot of different things, but on top of that, it's also a very hard place to work in. And the reason why emergency medicine is so hard to work in is because of the volume, right? You can't really deliver 100% of the best care because you may be taking care of 6 to 8 to one time I had like 21 patients I was overseeing. So you had a lot of different things. And so when I was looking for emergency departments, I was looking for that quality. I was looking for leadership. I was looking for people who were there who could make me better, okay, as much as I would be doing the good work that I wanted to do. And so I landed at Lenox Hill. Lenox Hill is a really great place because they had amazing leadership there. And I started working there as an emergency department nurse. Quickly, shortly, probably about 3 to 4 months right after, I became a preceptor. And so at that time, there was an opening for a nurse educator role. And I was offered to become the nurse educator for Lenox Hill's emergency department, as well as Lenox Health Greenwich Village, which is the freestanding emergency room downtown. And so over here on the right, you can see me and some of my emergency department fellows. So I ran an emergency department critical care fellowship, which is basically a fellowship for brand new graduate nurses who wanted to be specialized in emergency medicine. And that's one of the beauties about being a nurse, is you have the ability to kind of specialize and the flexibility to kind of move wherever you want. And that was a really great part of that time because I learned how to be an educator. I was, when they offered me the position of the educator, I kind of was like, that's not me. Like, I'm not smart enough to be an educator. And, I had a lot of really great mentors and role models who kind of pushed me and said, no, this is what you need to do. You were meant to be an educator. And so it was really great because one of the things that one of my mentors kind of told me was to say, at the end of the day, being an educator doesn't mean that you're giving up the ability to take care of patients. It means that you are becoming a force multiplier. You're somebody who is going to, get everyone to really be, a bigger part. Your care delivery is going to be completely larger because if I'm teaching one person how to do one thing, it can mean that, they could be learning and being able to spread the information to a lot more people. And at that time, I also had the opportunity to go to nurse practitioner school. And so that's where I went to nurse NP school. I was part of Hofstra Northwell School of Graduate Nursing inaugural class. And it was the very first class of the school, and it was a really interesting time. There were definitely a lot of growing pains. Being the first class, you kind of learn how to roll with. Sorry, I think my presentation is going all over the place. You kind of learn how to roll with the punches. You kind of learn along the way, but we all kind of grew up really quickly as nurse practitioners, and we learned how to take care of patients as advanced care providers. And I had the opportunity to go back and actually teach where I am now one of the faculty members there. And it's really interesting because whenever I look at this picture of our graduate class, I think about how quickly our class grew, because we graduated in 2018 and we started working as nurse practitioners, and then obviously COVID happened and we really were challenged to become a much bigger thing than we are today. So what are advanced practice nurses? So for those who don't know what advanced practice nurses are board certified, typically master's or doctoral prepared nurses. And so we take care of patients in a spectrum of different things. There's typically 4 different types of advanced practice nurses. So you have nurse practitioners, certified nurse anesthetists, clinical nurse specialists, and then nurse midwives. In this field of a nurse practitioners, one of the things about nurse practitioners is that we typically take care of different populations. So I'm an adult gerontology acute care nurse practitioner. What that means is I take care of patients within a hospital. Family nurse practitioners typically take care of patients in a spectrum of care from from life to death. So from babies to neonates to elderly, and they take care of a lot of patients in a primary care type of setting. Emergency nurse practitioners obviously work in the emergency department, neonatal nurse practitioners, psychiatric nurse practitioners, women's health nurse practitioners, and pediatric nurse practitioners. So here are some photos of some of our great nurse practitioners at Lenox Hill. You guys may or may not recognize Cynthia Liapis, who is one of Dr. Langer's nurse practitioners. I believe she works both inpatient and outpatient, so she helps to care for the patients in the hospital as well as on the outpatient side. Here you have one of my friends, Sonia Matai, who is completing a hematology oncology fellowship as a nurse practitioner, so she takes care of patients with cancer. Radiation oncology, so patients who have cancer who need radiation therapy. Jacqueline Wentz is one of the urology nurse practitioners, so she does a lot of urological things. Nara Zapata is one of the other nurse practitioners who works as one of my counterparts. She was also one of the flight nurses for the health system. Kristen is an emergency department nurse practitioner. These are our nurse anesthetists, who are amazing, smart nurses who are able to do everything from intubation to delivering anesthesia for our patients to make sure that they're comfortable in the operating room. Cassidy Tobin is one of the emergency department nurse managers, but she's also an adult nurse practitioner. So she, is able to take care of patients in a different advanced practice role. So when I became a nurse practitioner, one of the things that I thought about is like, what do I want to do? What are the different things that I want to do? I knew I loved resuscitation. I love taking care of patients who are critically ill. And when I think about resuscitation, I think about this picture over here. And when I was a nurse educator at the time, one of the things that they did was they had handed me a pager and they said, hey, go to rapid responses, go to emergencies, etc. And this is kind of the picture when I think about what a resuscitation should be. But this is what I actually saw, okay? And so for anyone who ever works in a hospital and you think about if you've ever had to be involved in an emergency or anything like that, you'll see everyone and their mother is there. And what are some of the unique challenges that we have or opportunities that we have? Well, there's too many bodies in the room. There's lack of role delineation, battle of the services, technical skills, and limited space. And all of that leads to suboptimal patient care. And so I wanted to think about how can I utilize my knowledge and utilize my skill set to help better that. And so one of the things that I did was I created this role where I wanted to be able to train like you fight, right? Why do we do so much training? Why do we always go ahead and practice? And how do you get better? Because you need to train like you fight. I wanted to always have a plan, debrief, standardized response, and develop competency in all team members. And that's kind of what I do on a day-to-day basis. And so as a rapid response nurse practitioner or a clinical impact nurse practitioner, we elevate nursing practice. So we elevate the nurses around them, get them to think about things in a critical way, get them to understand what their interventions are. We help prevent unnecessary ICU admissions. So one of the things is when you get stepped down from the ICU, we want to prevent you from going back there. I work really closely with the physicians in supporting the house staff. So we have an internal medicine residency program here, and I work with them to teach them different things like procedural skills, teach them how to manage a patient. And that leads to increased patient safety, increased patient outcomes, better patient satisfaction, consistency with emergency response, and again, prevention of patient deterioration, because one of the things that we do is we constantly are monitoring patients to make who are throughout the hospital to make sure that they're safe. And so this is kind of what we do on a day-to-day. What is my every single day like? It varies. Every single day is different. Over here is a picture of us when we were working in the COVID ICU. So there I was working with a lot of residents, teaching them procedures such as placing a central line, an arterial line, etc. We were helping them to manage patients. So whether it's working on a ventilator, etc. I'm involved in a lot of resuscitations. Obviously, I do rapid response, stroke codes, like cardiac arrest codes, etc. And so, this is like a picture of us in the ICU with a lot of different team members who are involved in the patient care. And this was someone who, was hemorrhaging, so we had to give a lot of blood for this patient. Again, one of the things why I love my job as a critical care nurse practitioner is that I love to critically think. I love to be on my feet and kind of be like, hey, what are the things that's going on? So I could have someone who's like in cardiogenic shock, someone who is in obstructive shock, and trying to utilize the tools that are given to us to kind of be able to think about those things. This is interdisciplinary rounds over here. So you can see over here, Dr. Karpati is leading interdisciplinary rounds. Dr. Karpati is one of the intensivists that I work with that, I give so much credit to my intensivists for helping to lead the way, but also for teaching me so much. That's one of the beauties about medicine, is that you'll never stop learning no matter how long you do this. I've been doing this for over 20 years and every single day I'm learning something new. So, again, being part of the team, helping to make decisions. This is Sasha. Sasha is one of my new nurse practitioners here. I'm trying to teach her how to perform intubation. And so we're practicing all of the different skills. I'm involved in helping out with providing education for our team members on resuscitation. So not only are we resuscitating, or my team is resuscitating, we're also teaching our team members how to do those things. So over here, you can see we utilize simulation for that. This is a scenario of a patient with a GI bleed who's actively hemorrhaging, and how do we resuscitate a patient like that who goes into cardiac arrest, trying to figure out what is the reason why the patient's in cardiac arrest, etc. I teach the fellowship as well as I teach new novice nurses a lot of different things. So one thing that we talk about in the ICU is the equation for blood pressure of equaling cardiac output times SVR. And so we talk a lot about, again, trying to translate, like I said earlier, when you're learning on the job, you may be learning a lot about like the technical skills. You're learning like, if this, then do that. It's very algorithmic. But understanding the why behind everything you do is super important, and that's something that we do. We also train our residents here on how to do different advanced procedures. So this is talking about placing a central line, again, decreasing central line associated bloodstream infections, teaching everything from sterile technique to the actual procedure. And so when I think about and I reflect, what is it that I do every single day? There's 4 different realms of kind of what I do. So I work in the intensive care unit, and I also do rapid response in the hospitals. This is a photo here of what happened during COVID. So this was in our COVID ICU. And typically, these are complex patients who require a lot. And you can see everything from the different devices that this patient has, the patient's ventilator settings, the number of drips that these patients are on, all these different medications. And that's one of the reasons why I feel like I really enjoy critical care, is I love being able to provide care for patients and families during a time of need, and being able to think, right, and understand those things. One of the other things that I still do is I do hold a per diem job as a critical care transport nurse. And when I think back to the days of my ambulance time and working with EMS, it's kind of my guilty pleasure of being able to kind of go and still deliver care on a moving vehicle. So I do that. I also work and I teach on the undergraduate level, specifically simulation. So you can see this is a case of a patient. And if you're able to see, you can see some really abnormal vital signs over here. So we're able to teach our undergraduate nurses how to become, strong nurses. And then I also teach as a on the graduate level, nurse practitioners at the Hofstra Northwell School of Graduate Nursing. And so going back to thinking about what I do on a day-to-day basis, so I kind of wanted to show some scenarios of some things that we try to figure out. So this is a rapid response for a patient who has breast cancer, who's complaining of some shortness of breath. And so one thing that we utilize a lot, that you guys, if you're going into medicine, will utilize, no matter what field you're in, you may utilize this, is the use of ultrasound. And some people will say ultrasound is replacing stethoscopes. So traditionally, people always attribute medicine, they think about utilization of a stethoscope, but ultrasound shows you a lot of different things, because you can look at organs and everything like that. So over here you can see a normal 4-chamber view of a heart over here, and you can see over here, you can see all of the chambers of the heart, and surrounding it, if you remember any of your anatomy from your heart, you'll know that there's something called the pericardium, which is like a big sac. Over here on the right, you can see an abnormal image over here. So this could be the patient who's having shortness of breath. I go ahead and put a probe there, and you can see that the pericardial sac, this black area, black on ultrasound typically means fluid. You can see that there's a lot of fluid surrounding the heart, and that will go ahead and obstruct the way that the heart has the ability to pump. And you can see this is also known as like a swinging heart. You can see the heart swinging back and forth in this pericardial fluid. And so in somebody who's in shock, right, they're specifically obstructive shock because they're not able to have any forward flow of the pump. What we would do for this patient in an emergency situation is do something called a pericardial centesis, where you're going to go ahead and draw out, it could be blood, it could be fluid, so that you can decrease the amount of pressure over here on the heart, so the heart has the ability to flow. This is a case of a patient that we took care of during COVID. So I thought this was a really interesting case to kind of show what it's like to work in critical care, a day in the life. This is an elderly male who kind of went through multiple ICUs, history of diabetes, coronary artery disease after a CABG, hypertension, who was admitted for COVID, intubated for acute hypoxic respiratory failure. He had a prolonged course in the hospital, so we were seeing a lot of patients who had clotting issues, which he had a GI bleed, tonic-clonic movements, acute renal failure, and difficulty weaning. And so he was prone and started on sedative medication for vent synchrony to improve oxygenation. So we were proning a lot of patients because your lungs are longer in the back and it allows you to ventilate better. And so I was called to the bedside for hypotension. They said that his blood pressure were dropping. He was already on blood pressure medicines. They were increasing the blood pressure medicines. They were increasing very quickly. And then they also had hypoxemia. His pulse ox kept dropping on 79 and on 100% of oxygen. And so I played around with the ventilator settings. I, collected an ABG to confirm this, right? And the patient was on full ventilatory support, including the use of nitric oxide, which helps us to, oxygenate a little bit better. And so I would change everything, and then all of a sudden he would get better, and then he would get worse again. They'd call me back like 15 minutes and like he's getting worse again. So what we would do is we were increasing his pressor requirements, his medications that keep his blood pressure up. Then they would start coming down on it, and then he was doing okay, and then 15 minutes later, crash again. And so I had to make a difficult decision at like 4 a.m. to say, okay, well, we need to unprone this patient so I could see what's going on. And the use of ultrasound, I would go ahead and put the ultrasound on, and things that I'm checking for is I want to make sure there's no pneumothorax, so I can look at lung sliding. I want to make sure there's no effusions, right? So that is he having a lot of collection of fluid in his lungs that's causing him to drop his O2 saturation. I wanted to look to see if he had a pericardial effusion. So I put the ultrasound probe, just like with the last image over here, where you can see that he has an effusion, a large pericardial effusion causing a tamponade physiology, to look at those things. And then here, I wanted to also make sure he didn't have a blood clot. And so one thing you can see over here is that this is the right atrium, right ventricle, okay, left ventricle and left atrium. And you can see that there's something right here, this white area. It looks like a white little ball bouncing back and forth in his right atrium. He had a clot in situ, right? He had a clot that was in the right atrium that was obstructing forward flow. And so that's when we decided that we were thinking about, we need to give TPA to this patient before he was going to code, even though he had a risk factor of a GI bleed. But again, this was kind of the cool thing of one of the things that we do every single day. So what were some of the lessons that I learned? I learned that life is incredibly short. You never want to take anything for granted. Everything that you learn, and you guys have been part of the Brain Turns program all summer long, you never want to take it for granted. And you want to take everything as a lesson. And always be open to learning new things. I think if you get to a point in your career where you feel like you know it and you know it all, that's a time that you become very dangerous. So you always want to be open to learning new things. No matter what happens, always chase your passions. Don't sell yourself short. I was very lucky. There were a lot of people who believed in me before I believed in myself. And they really kind of challenged me to be better. And at the end of the day, you always want to know the why behind everything you do. And at the end of the day, remember that we're all on the same team, no matter what role you play, whether you're a housekeeper, you're a respiratory therapist, you are a neurosurgeon, you're a PA, you're a nurse practitioner. We all work together, and you need to find value of everyone on your team because nobody can do it alone. And so with that, this is my contact information. If you have any questions, feel free to reach out, and I guess we'll open up if anyone has any questions.
That was so incredible, Andrew. Thank you so much for sharing.
Thank you for
awesome. Of course. Okay, so let's see. We have a couple questions. Olivia asked, most cities have more affluent parts and then lower income parts. Do you think growing up in a city helps you see the differences between these areas? Does it help you understand better a patient's capabilities to maintain their own health?
100%. I think that one of the things growing up in New York City, you know, especially when I worked in EMS, there are definitely, you know, areas that, you know, come from a lot of money. There's areas that don't have those resources. And that's the thing that we have to remember in healthcare. We can't assume, right? You know, whenever you assume, you make a fool of yourself, right? You always have to have that understanding and try to gain that understanding. And that's one of the things that why I loved about nursing is that the nursing theorists always talk about getting to the level of the patient and understanding where they're coming from and then meeting them halfway. You can't expect someone to change. You can say, hey, I want you to stay away from sugary foods, etc. But it's really hard for them, right? And you have to understand what are those challenges. I think about alcoholism. How many times do I see people who have alcohol withdrawals, right? I actually have friends who are alcoholics, and it's hard. And as a friend, it's even harder because you want them to change and you want them to do better for themselves. But at the same time, it's really hard because it's a chemical thing, right? And when I talk to some of my friends, and I've talked to people who are struggling with those things, they always say to me, they're like, oh, well, you know, I get disappointed in myself. I really don't like myself because I gave into it, or I feel like it's controlling me. And I have to remind them at the end of the day, it's not about them. It's a chemical thing, right? And so meeting your level of where your patient's at, understanding population health literacy is super important.
Thank you. Yeah, I agree. Health literacy is really, really important. This is funny. She has my name. This is from Ashley Rosenberg, but I did not ask this. Okay, yeah. Ashley is, I don't know if whatever. Anyway, that's like tripping me up. I'm currently in nursing school and sometimes have doubts and low moments as I feel I'm not smart enough and it's hard to remember everything. Do you have any advice for that?
I would say learn the way that you learn. And I would say that never doubt yourself. You will always feel that way. There are days, I've been doing this 20 something years, where I'm like, oh my God, I don't know anything, right? And I think that if you understand the why behind everything you do, don't learn it based on, don't learn anything in medicine based on the fact that like, oh, so I teach undergraduate level and we talk a lot about the sciences and everything like that. And if you learn things like, I always like to tell people, I use the example of heart failure, right? So one of the things you learn about heart failure is you remember right-sided heart failure. You have to remember that the patient can have jugular venous distension, that they're going to have swelling of the legs, etc. And then you think about left-sided heart failure and you're like, oh, they have pulmonary edema and all of these things. But I always tell people, if you understand it on the basics of science and you can say, hey, and you can tell me that the blood goes from the superior inferior vena cava into the right atrium, through the tricuspid valve, through the right ventricle, out to the lungs, then back from the lungs to the left atrium, to the mitral valve, to the left ventricle, out to the aorta. Then it's all plumbing, right? Because then at the end of the day, you can say, oh yeah, so if I have a blockage, my left ventricle is not pumping well, what's going to happen? Well, it's going to back up into my lungs. Oh, okay, so that's why they have shortness of breath and they have pulmonary edema. If I have my right ventricle is not working, well, what's going to happen there? Well, it can't pump blood forward. It's going to back up. I'm going to have jugular venous distension. I'm also going to have pitting edema. So I would always just, my thing is I always tell people, and I tell that to all my students, always know the why behind what you want to do.
Andrew, I can't believe at one point you thought you wouldn't be a good educator, because that literally made so much sense.
Thank you.
Yeah, I think, yeah, that was so well explained. And I think that's important to you. For a lot of the people, they ask like tips for MCAT and stuff like that.
Yeah.
And it's like knowing the why is a lot better than just rote memorization, because
Yeah.
it's like it'll help you think through questions a lot better. Why is so important. Griffin agrees. Someone said you don't look a day over 30.
Oh, thank you. It was my birthday actually yesterday, so I turned 39 yesterday.
Happy birthday. Okay, very cool. So let's see. Were you on TV, Andrew, talking about COVID?
I was, yes. Yeah, I had a lot of great opportunities that they wanted us to share about our COVID experience. You know, it was a very challenging time, and it was a time that, you know, I always tell people in pulmonary critical care, you know, working in critical care, that's like our Super Bowl that nobody ever wanted to be involved in. You know, and so, yeah, so I was on television, yes.
Are you able to share a little bit more about that experience? And
Sure.
not the being the working.
The COVID, yeah. So I'll tell you about, you know, COVID was a really interesting time. And, you know, I've been around for September 11th. I've been around for a lot of other tragedies that have happened. And COVID probably was one of the hardest ones for me, in the sense that we were just watching so many people pass so quickly. And anyone who knows me knows how much I love taking care of critically ill patients. The sicker they are, I don't want the patients to be sick, but I want to be there when they are. I actually, when I worked at Stony Brook, one of my going away gifts they had gotten me was, they said, I love trauma, not that I want you to get hurt, I just want to be there when you are. And that's always been my personality. And so during COVID, we were just seeing so many sick patients, and it was happening so quickly. And initially I was just like, okay, you know, we thought it wasn't going to be that big of a deal. But when you turn around and the entire hospital is an ICU, and you're walking down the hallway and everyone is on a ventilator, and you're taking care of you're taking care of, normally like in the ICU as a provider, you might be taking care of 12 patients, and you're taking care of like 18 to 20 patients on a ventilator. And then the resources that you have were not there, in the sense that, you know, Northwell was really great. We had every single resource, but resources in meaning of manpower, it was overwhelming. Like, we tried our best to get as much things that we can have, but like, you know, things like, you know, everyone was scared. You were also scared about, like, you know, bringing this stuff home, right? At the end of the day, like, people's families, you know, I still remember one day thinking about the power of me ordering dialysis. dialysis at the bedside in the ICU is complex. It requires a lot of different things. And there was one day I had an older nurse who I had asked to start dialysis. And one of the things that she said to me, which was really made me think a lot, was she was like, it's really difficult for me because I'm really scared to go into the room. And that's where I jumped in as a team member and I was like, I'll do it or I'll go in with you. But I completely understood the fear behind that, right? Because she was at risk and she had to do this complex procedure and everything that we were doing anyway wasn't working. And so that was a really scary time.
Yeah, that is really, really scary. And thank you for being so strong in helping patients during this time. It's amazing what nurses do. Yeah. Okay, let's see what other ones. Oh, you're a real life hero. Thank you so much for all that you do. Very cool. A lot of happy birthdays.
Thank you.
Cancer.
I know I want to save this so I could like read it later on.
I actually can send you if you want to see the chat at some point. But okay. Someone asked, this is like a more practical question. How long should you practice as a nurse before considering going to NP school?
Sure. You know, it's interesting. So there's different pathways, right? So there are some pathways that they have like what's called a direct entry, and it's like go in and becoming a nurse. One of the great things about becoming a nurse and then ultimately a nurse practitioner is you get a lot of real life experience prior to even becoming a nurse practitioner. And those things are super important because at the end of the day, it's one thing to say, I read in a textbook that when your urine output, you know, that when your blood pressure drops, that, you know, oh, I should be looking at this, or I should be starting them on vasopressors. But it's different when you go ahead and you're a nurse and you're able to say, hey, I recognize that the urine output dropped off like 20 minutes ago. That's not a good sign, all right? And you can catch that beforehand. Or it's one thing when you can say, hey, it's subtle clues. You know, one of the things that I always do, I do rapid response. So a rapid response is like anytime, I don't know if I explained it earlier, but it's basically anybody who's deteriorating within a hospital, anybody can call a rapid response. And I always describe to people, and one of the things when I give this presentation, I always say, if you think about where I came from and where I started off in emergency medical services, all I did was bring emergency medical services into the hospital. I am the paramedic of a hospital, right? I go there and I'll go and stabilize the patient and then transfer them to where they need to go. But when I'm there and during emergency responses, I always talk to the nurses and I say, hey, you tell me what happened, right? And it's them who are able to give you the subtle changes. Oh, I noticed that he had a facial droop. Oh, I noticed that, you know, he just isn't acting himself right now. And so that's one of the things that I would say, the question, going back to that question, is that you want to get a few years of nursing experience prior to becoming a nurse practitioner. Sure, there are programs that will drive you directly to getting to that point, but then you're really doing a disservice for yourself and you're doing a disservice for your patients because you have none of that hands-on clinical experience.
Got it. Thank you.
Thank you.
I think totally answered that question. Kayla asked, how did you handle being in healthcare at such a young age? Was it ever overwhelming?
For me, it wasn't. I was that nerdy kid who, you know, that it was cool for me at the end of the day. I think at a young age, you're never too young, you're never too old, you know, as long as you're passionate about it. So while other people were playing, I guess, with other things, I guess, for me, I was playing in the back of an ambulance. So, and that's, you know, it's balancing both those things and finding your passion.
Amazing. So we just have a minute left.
Sure.
Thank you so much for your time, Andrew. If you want to end on like, you know, just one last word of advice to the crowd for people that are interested in healthcare.
Yeah, I'll tell you, you know, my final thing that I'll say is going back, and I've said it again and again before, always know the why behind everything you do, because at the end of the day, it will help you do better for your patients. Your patients will have a better understanding of why you're doing what you're doing. And then always just remembering that at the end of the day, it's a team approach. When you think back in the days when, especially when I first started in healthcare, it was the doctors who were doing everything. Nowadays, I think any strong physician will tell you that they can't do it by themselves. It's really a team approach. It is the doctors, the nurses, the nurse practitioners, physical therapy, environmental services who are all involved in the day-to-day care. So, but thank you.